Noted, I have a background in both public health and data visualization. My data viz career grew out of my public health career. So my hope is that today you can take away a few tips on not just being better visualizers of this data, but perhaps some considerations on how we can be better consumers of the data around COVID-19 and some of the special considerations we have in a pandemic situation. So we all know that COVID-19 charts are everywhere. You can't open a major news outlet. You can't open the New York Times. You can't look at a print publication and not find some chart or graph trying to make sense of COVID-19. It's interrupted and disrupted the world. And so it's been top of mind, not just in any one country, but in countries around the globe, which is why I'm delighted to be speaking to you today from Washington, D.C., to many of you who are across the Atlantic and joining us from other countries. You see all these different charts and graphs that try to find different ways to plot information, bubble maps, different line charts, bar charts, heat maps, small multiple tables. There are all different iterations of these charts, many of which have really helped to enable public understanding of what's happening around COVID-19. So I want to say up front that I think data visualization has been a powerful tool for making sense of COVID-19 data for many people who otherwise wouldn't have a way to understand what was happening either in the world or in their communities. We've seen ways in which different models are rendered as maps or as different charts or graphs to try to help us make sense of the model itself. A lot of us can't read the SEIR inputs and the various functions over here on the left, but you can interpret and understand what the output is. Here, for example, looking at where there is elevated risk of hospital overload. Today, I'll be focusing a lot of my examples coming from some of the US context, just because it's what I've been following the most closely and know the best. But many of the same principles and ideas are applicable regardless of what country you're in. We've also seen ways that visualizations, though, have been used to mislead or unintentionally mislead. A graph that made the rounds here in the US was around this graph from the state of Georgia as they went in their process of reopening their economy. And you can see if you look at the x-axis that the dates look a little bit out of order. And whether this was just a pure accident, someone pressed that sort button and sorted by values instead of by time, or something intentional, we really don't know. But there are ways in which visualizations not only can inform, but mislead, and mislead in unintentional ways. And that's in part because there's such easy access to the data itself. The underlying case data, the death data around COVID-19, which Harry very aptly explained, is very flawed and incomplete for a number of different reasons, is made very available. When we have data sets that are made easily accessible and machine readable and easy to plug into a tool like Data Wrapper or Tableau or Flourish, it makes it easy to quickly spin up charts and graphs that appear very accurate and very easy to draw you in. But if you don't understand the underlying data, it's easy to mislead. We've even seen this with forecasting and the ways in which different forecasts and models are built around COVID-19. This is a nice screenshot from the Reich Lab, I think from a few weeks ago, actually, looking at different forecasts and where they predicted the US would be around COVID-19 cases and deaths. And you can see that it includes multiple different models with different methodologies, as well as the various confidence bands. And those confidence bands are wide, and in many cases, not even overlapping. So these different mathematical models aren't agreeing with each other. The challenge that we face, though, is how do we reconcile our need for evidence as a broad public community looking at this information and wanting to understand what's happening with COVID-19 and our enthusiasm for charts. We as humans love interacting with charts and graphs because they make information accessible through visual forms, with the uncertainty that exists in the case data, the uncertainty that we can't quite correct for, the known uncertainties and the unknown uncertainties in how data is collected. That gets even more complex as we start to make comparisons across different states or countries where the methodology may be different. So I think we can start as both designers and as readers of charts and graphs with having a better understanding of the data itself. So I want to call out a few specific things to look for as you're looking at COVID-19 case data, either to create graphs and charts or reading them. One is just the simple question of how we define a case. There have been changes in definitions to cases and ways that cases are counted differently. Are we looking only at confirmed cases that we have a laboratory result for, or are we actually adding in probable cases, cases for which we suspect pretty robustly that they are COVID-19, whether it's diagnostically or via some other test or exam, which could give us different counts of total cases. You can see here, for example, in the state of Ohio back in April, looking only at the laboratory confirmed cases here, confirmed in a specific set of laboratories, might be different than the total case count. And as we start to compare countries, we want to understand what's being included in a count of cases. So as you go and look at the data, and as you look at charts and graphs, look for those definitions describing what a confirmed case is. We also have to think about how that definition has changed over time, not just in different, not just across our own kind of environment in our own country, but also as we look around the world. So for example, in this sample chart from Data Wrapper, you can see that there's actually a reference line showing where China changes the way it collects data. Back in late February, early March, when we had many more cases in China than any other place in the world, we saw a really big bump or spike in that chart. And so it was important to annotate that with information saying, you know, the reason that we see this change is not because there's necessarily been a change in the epidemic or in the way the disease actually interacts with or infects people. It's rather just that we have a change in the way we're detecting it. And understanding what kind of variance is in the data due to reporting lags or detection or new testing is going to be different than understanding the ways in which the data is otherwise quantified. We have to understand how routine monitoring data is collected. This was the world I lived in for a while, was looking at national health information systems. How do we collect information on various diseases, both reportable diseases like COVID-19 or HIV, but also looking at other just endemic conditions that we care about in a health system. And collecting that data is complicated. I don't know that any of us have spent a lot of time really thinking through all the different nuances of how data gets captured. And out of my blind curiosity, I've actually started doing some interviews with different folks I know from my public health days in Canada, in the US, in South Africa, asking them to walk through for me, how is it that you go from someone actually feeling like they are sick and needing to get tested to having an actual test result appear in a national database? And so an illustrative journey map of different steps that could happen, this isn't specific to any one place, is complicated. There are a lot of steps. You have to go get tested, the swab gets taken, the patient data gets entered into an information system. Maybe that's in parallel to the national system. Maybe it's looking at the, specifically looking at the information that we're seeing in information system at the clinic rather than seeing it in a lab. There's a lot of complexity here, right? And so as we look at this, we see all these different steps. And each of these steps take time. Each of these steps might take a different amount of time depending on the caseload and have a lot of uncertainty before we get to a positive case result appearing in the national statistics. There are all these different things that could happen, right? Are there paper forms? Is there data entry errors? How big is the backlog to run the test? Has it changed over time? Did test results used to take 2 days or used to take 12 days and now they take 2? Do private tests have to do secondary confirmation at a national lab? Same system. All these different nuances around how that actual process of getting that confirmed case record into our national statistics make it really challenging to look at and compare data in some ways. And it's not anything intentional or anything that someone is trying to make this an overly cumbersome system, though I would argue in some places there are certainly some efficiencies. But we have to think about the ways in which there are people involved in all of these different steps, and there is complexity, which is one of the reasons why epidemiologists usually pay far more attention to the trends indicated by epidemic curves, this case count that happens on a daily basis, changes in the timing and slopes of their rise and flattening and fall, rather than the case numbers themselves, which is funny because we have focused so much on looking at that new case count that happens every day. But that case count that I'm going to see for DC tomorrow represents tests taken a few days ago or a week ago even in some places. And so I think we need to be thoughtful about the ways in which we're looking at data and focusing so much on these daily counts and numbers, when really it's the shape that matters the most, and understanding what are the different levers impacting that shape. We also have to look at studies. There's lots of preprints floating around out there that haven't been peer reviewed, and preprints help us get access to research and information faster in a situation like a pandemic. But in some cases, people like journalists will go ahead and pluck a number out of a preprint that actually perhaps might mislead when brought into this inflammatory headline. Here, looking at the number that got shared around of 88% of COVID-19 patients on ventilators didn't survive. Now, if we go back to the actual study and go back to the table that's in JAMA, the Journal of the American Medical Association, a reputable journal that I would trust their information, and we dig in, we find that that 88% number is here. Patients who died of those who did receive mechanical ventilation. The issue we have, though, is that the denominator is flawed. that 320 cases does not represent people who are still in hospital on ventilators and presumably alive. And so we saw that journalists actually had to correct their headlines after that was called to their attention. You can see that when we looked at how CNN corrected a headline, for example, they had to change their headline from nearly all patients to about a quarter. And those are two very different messages, right? And that's important that we go ahead and hold journalists and others to account in how information and data from complex medical journals is being translated into more accessible information in headlines and in charts and graphs that are shared through the news media. Journalists have been doing tremendous work. I applaud the different data teams at Reuters and the New York Times and the Washington Post and NPR for just the level of effort they've put into creating charts and graphs to make data accessible. But that doesn't mean that there aren't mistakes made or misunderstandings around how data gets amplified and the ways that different percents or numbers or calculations may seem like they make sense on the surface, but really have much more epidemiologic complexity. Another consideration here around data is, what are our known unknowns? Where do we just not have enough information to make a statement or summarize information in a really shiny, pretty bar chart? So, for example, here, looking at the first report that came out from our CDC, focused on the share of different patients with COVID-19 who also had pre-existing conditions that showed that they may be more likely to be hospitalized or put in ICU. Wow, when we look at this complex MMWR, it's a technical report. It's not very visually engaging from the start, but has a lot of rich information. And NPR did a great job summarizing that information into a simple bar chart. Instead, they went ahead and did some quick calculations. They clearly noted their sample sizes here on their y-axis. And they showed the percentage of patients with COVID-19 confirmed cases who were known to have a pre-existing condition. And you can make a comparison between those who were known to have a pre-existing condition and those who had no pre-existing conditions. But when I looked at this chart, I could think back to the end of March, which is when this was originally published as data. And I saw this number in the footer that said 6,637 cases reported. That's how many are represented in this chart here. And those were the ones with complete information and hospitalization status. That's all that data collected in that routine form about routine monitoring of these cases. And if we go back to the actual table in the actual MMWR, we see a summary in bold at the very top of the table of just what a large share had information unknown. So I think it's important that we be really honest about what we know or don't know when we're publishing charts and graphs and summarizing them. It's easy for this chart to be something someone sees and says, oh, look at 27.7% of people with chronic renal disease end up in ICUs if they, end up with COVID-19. But that's not quite the case. This isn't generalizable in that way. This is 6,637 cases out of, at that point in the US, around 122,000. And there's enough uncertainty around COVID-19 that we shouldn't have to go ahead and ignore the uncertainties we can quantify. This is a little graphic from the 538 article around why it's so hard to make a COVID-19 model, and a good one that projects and forecasts what could happen. And with all of the different unknowns that we have with a new virus, it's really important that we're at least honest about where there are unknown unknowns, those gaps in our data and information by nature of just what's being collected and reported. So as we think about all these different complexities and nuances, I think it's fair to ask, how might we viz responsibly? How do we create responsible, informative visualizations that at least minimize the risk of misleading someone? First off, before we start any design process, I think we really have to align on our values and how our values may shift and change and require different considerations in a pandemic situation than they do when we're actually visualizing data about, say, sales or marketing or something else where the impact of our choices may be less challenging from a human perspective and from their potential impact on human life. Bridget Cogley, who's a Tableau Zen master and writes a lot about ethics and data visualization, has a great article on the ethics of visualizing in a pandemic. And in it, she talks about this idea of value prioritization and alignment and how our values may shift across these different categories. Things like autonomy, sanctity of life, do no harm as a principle, trust, justice. These are all things that we have to think about regularly, especially when visualizing data around social issues or social good or health in general. But in a pandemic, the onus is on us to be even more thoughtful about how our visualizations will follow a do no harm principle, for example, and make sure that they won't mislead someone to think it's not important to continue to do physical or social distancing. So as we think about practical things you can do as readers or creators of these visualizations, first, you can seek or demand honesty about the uncertainty in the numbers. You can look for what the total sample size was and ask questions. You can look for actual outlets or articles or websites that clearly state their methodology in terms of how they're quantifying and explaining how different states or different countries are being measured, how they're being told that they're doing well or not doing well, and being really specific there. And even more, being very clear on what data is missing from the picture that we have right now. Again, we have some known unknowns and we have unknown unknowns. Let's at least state what those known unknowns are in terms of what data is missing. And these examples are from a site called covidexitstrategy.org that's been built out for the US states by a collaboration with the US Digital Response and a few other groups. I had a conversation with Ellie Murray, who's an associate professor of epidemiology back at my alma mater at BU. And she commented that the most legitimate models and graphs are going to be very explicit in their limitations, their assumptions, and what's included. And they'll tell you what it is they're showing you. If that information and that clarity isn't there, it's okay to just not look at that chart or graph or ignore it. If you see something circulating on social media and being reshared on Twitter with a bunch of numbers in it, but no clear data source or statement on limitations, think twice before you click retweet, as compelling or beautiful as that visualization may be. There's also ways in which we've seen different outlets work to go ahead and annotate their charts and graphs to make it clearer and easier to understand. Here in this example from Data Wrapper in their responsible charts of COVID-19 selection, they actually are very specific on what these different lines and additional explainers are meant to do on this chart or graph. 2 is to always consider the people and the stories represented in this data. Looking at case counts climb and climb and climb and deaths climb and climb here in the US, I think we've been staggeringly disconnected from what those actual numbers represent. And that kind of brings us back to some basic principles of data humanism, which was coined by Georgia Lupi, and focuses really on data as people, not just numbers. She and her team at Pentagram did a reimagining of what we could look at in terms of visualizations of things like lives lost. And so here, for example, with some slides she readapted from Andrew Cuomo, the mayor of New York City, or the governor of New York. She actually looked at a different way to show an array of the lives lost and look at that over time, kind of giving this effect of a starry night sky that shows the density and the number of lives lost, but doesn't simplify them down into a count or a bar chart. I've also found that images are really powerful in how we communicate. So it's not always about charts and graphs, but about imagery and other ways of making a connection to the data. Here we see these mountains of potatoes that are currently being discarded in Idaho because there isn't the necessary demand because of all the restaurant closures for where they would normally go in our supply chains. And we also see lines and lines of cars lined up outside of food banks throughout the US seeking support and outreach in terms of getting food for their own at-home dinner tables. And so as we look at these two things next to each other, a whole excess supply of food and a whole number of people who are seeking and looking for food supplies for their families, Jose Andres asked the question very aptly, I want to talk about 2 photos that tell the story of food in our country in this moment, 2 different painful realities we're experiencing, and talks about how this is an opportunity to talk about how we reevaluate, reassess, and rethink our food supply chains. And so these things, like these images, are far more impactful to me when I see them than just looking at, say, a count of the pounds of potatoes thrown away and the number of people who lined up for a San Antonio food bank. Third, you can collaborate with subject matter experts like epidemiologists, but also virologists, biostatisticians, public health experts, and others. Epidemiologists are great resources, and especially those specializing in infectious diseases. But this challenge of COVID-19 goes far beyond just understanding the disease itself. We also have to think about the economic implications, about the public health implications around human behaviors and choices. And there's a great game that was created by Shirley Wu and Stephen Osserman called People of the Pandemic. And it simulates, not with a bit more complexity than a simple simulation that runs as you scroll down a page, it simulates what happens based on your own individual choices. So you go ahead and you enter into the game and you go ahead and identify your zip code. If you're in the US, you can do that, or select if you're in an urban, rural, or suburban environment. And then you go ahead and you actually play the game along with 19 other real people. Maybe not at the same time, but their choices also impact the outcome of your game. And these people have all played before you, and they also made certain choices about how often they went out of their house or didn't throughout the course of a given week. And the game plays over 5 weeks, and each week you're asked to decide how many times they'll go out for groceries, go out for a walk. And these different choices are weighted differently. The impact of you going to a gathering of 10 friends is weighted differently with greater risk of spread of disease versus actually looking at the risk of spreading disease if you say go to the grocery store or go out for a solo walk. And they have a great disclaimer on this that says very pointedly that this is not the COVID-19 data itself. It's really about kind of simulating what happens and what happens related to hospital capacity. As you play this game, you'll see little dots flitting in and out of houses, but also see hospital beds fill up at an illustrative hospital. And when you look at who they collaborated with for this game, it was not built in isolation by a couple of developers. It had people who had data visualization expertise, had someone who was a master in spatial analysis for public health, that's Stephen's background, as well as other consultants, visual designers. I gave some input from a public health perspective. There were a number of folks they consulted throughout the process. And look for these kind of collaborations as you're vetting what kind of simulations or games or models are actually giving you good quality information. Fourth is to seek feedback. How could what you've designed be misunderstood or misused? We often see that there are people who put wonderful, beautiful things out in the world and don't think about how something could be misused. One example could be Ken Fleur-Lage did a great kind of visualization where you can plug in your own office data and identify where you have a 6-foot radius around your staff members if they were to come back to work. But that doesn't kind of take into account all the other complexities around air circulation, wearing masks, how I interact with and move in and out of conference rooms or the kitchen. You could even see things that focus more on the COVID-19 case data, that focus on this gradual reopening idea. Christian Felix did a beautiful job explaining all of the statistics behind this and how it was created and why it was created a certain way in an article that we have on the Data Visualization Society's publication, Nightingale. But you can easily see that if you look at this, it's looking at blue being having consistent declines in total case numbers, orange being consistent increases. And it looks at a county by county level, and presumably the more blue the state gets, the safer it may be to reopen. So you can see someone looking at this and saying, look at, everything's going fine. Most of the counties are blue. We should go ahead and we can reopen. But there's so much more complexity to this that you have to go ahead and unpack around decisions like how to increase the amount of movement people have around a community and removing shelter-in-place orders and allowing other businesses to open. It's not as simple as whether a map turns blue or orange. It's about all of the other policies and things in place to keep people safe and protected so that we're making practical recommendations. There's an article in The Atlantic talking about how quarantine fatigue is real, and it is real. We know in public health communications, we saw this with early HIV prevention messaging, that just telling people that they have to kind of shut down their lives and stop doing something for the perpetual future is apt to go ahead and get people to say, well, I mean, I just can't and I won't. Rather, we should be saying, here are the practical steps you can do to mitigate and minimize the risk to you and your family and household, but also minimizing the risk to your community and those who are high risk in their environments. Fifth, and finally, seek and look for other data besides the case and death data. As we've talked about multiple times in this session so far, there are lots of flaws and challenges in how the case and death data gets pulled together. So what else can we analyze to make sense of these months? Maybe that's non-pharmaceutical interventions like requiring wearing masks, or maybe it's something like looking at excess mortality. If we know that we're undercounting COVID-19 deaths, we've seen various outlets, here are the Financial Times, also groups like The Economist, going ahead and plotting the lines for the expected number of deaths for each week that we see in different countries, and what the excess, the shading here, may look like for different countries. And so as we look at this, it gives us more information about where we may be undercounting and underestimating the impact of COVID-19. We don't know that all these excess deaths are COVID. There are so many other reasons why having a health system that's overloaded or having elective surgeries put off or people being afraid to go to the ER may result in other deaths not caused by COVID-19 as an infection, but rather that are kind of knock-on effects. And all of these things we will quantify and study, I promise you, in public health for years and decades to come. You can also look at simple things. There's a great kind of small multiple chart that the COVID exit strategy group did that gives me all the different metrics I might care about around the trends, rolling averages, Influenza-like illness, things that may not be tested as COVID-19, but that we catch in our flu and influenza tracking systems, ICU bed availability, and testing. How many people get tested, and whether we're testing only people who are presenting with symptoms and are sick versus testing a broader swath of the population, because of how asymptomatic some folks can be, is really important to make sense of what's happening with cases. If I'm testing a lot fewer people, I can expect that I'm going to find fewer cases. So if you're doing yourself any amateur analyzing, modeling, visualizing of COVID-19 data because it's out there, because you find solace and comfort in exploring and understanding the data for yourself, I would ask you just one specific thing, which is to pause before you publish into the public domain. Remember that first do no harm principle? Think about the ways in which someone might see or misunderstand your visualization. Make sure that you've gotten some vetting from someone else to make sure that it's clearly understood and has all the notes about the various limitations in the data, and that you understand the data you're using. I know a number of different people who are leaders in the data viz community who have chosen not to publish any of the graphs and charts they've been creating on their own because of the fact that it could mislead or misrepresent information, because they don't have a strong background in public health and what the data means. And so please, as you're thinking about creating visualizations and infographics, pause before you publish. And remember, first, think about how we can do no harm with our visualizations. I think we're all well-intentioned, or at least I hope we are, in communicating data effectively. So I'll point you to a resource, because we know that people will have to visualize this data, whether it's for their jobs or for their local newsrooms or otherwise. And so Catherine Hepworth out of Australia, she's a professor out at the University of Nevada, and I and a few others collaborated on a practical list of ethical design recommendations around how to carry out a more ethical and thoughtful design process in dealing with something as complex as COVID-19 data, with all of its uncertainty and with all of the different ways in which this information could be misrepresented or could be harmful in terms of how it's presented to people. There's a tiny URL link there. I'll also put it in the chat box. But if you're looking for additional recommendations on how to approach that, feel free to take a look at that article. It is on our DataViz Society Medium and Nightingale account, but this is a link for friends and family. So even if you don't have a Medium account, you should be able to access it. There's a few other resources I'd flag. DataViz Society is a great place to go for more connection and resources about data visualization. We have a number of articles about visualizing data responsibly around COVID-19, and have a video series around Biz Responsibly, talking to decision makers and people collecting the data, and various ethical design checklists also listed here. So I hope that this has given you some food for thought. I'm excited to hear what the questions are on the panel. And Lolly, I'll go ahead and hand it back over to you.